Before we proceed to the diagnosis, I will first read the case assigned to us, which focuses on the upper respiratory tract infections. A 28-year-old woman presents to the SWU-MC emergency room with a dry hacking cough. She indicates that she had a cough for approximately 5 weeks and has had a low-grade fever at times, but never higher than 38 degrees Celsius. She states that she has terrible coughing spells where it is difficult to stop and her sleep is often interrupted by coughing. Also, she has shortness of breath when she lies down. During the physical examination, the patient has several episodes of numerous rapid coughs, each followed by an inspiratory effort that includes a high-pitched whoop. Her vital signs include a temperature of 37.5 degrees Celsius, pulse rate of 160 beats per minute, and respiratory rate of 72 per minute. She confirms that she has never received a pertussis booster vaccine and is currently not on antimicrobial therapy. Based on the patient's symptoms and the nature and history of the cough, the resident suspects whooping cough. He orders complete blood count, nasopharyngeal culture, serologic test, enzyme-linked immunosorbent assay, and a chest X-ray. Results of the blood smears show increased WBC count with absolute lymphocytosis, with the culture of nasopharyngeal swab and gram stain is seen in Figure 1. Moreover, a serologic test revealed positive on IgA and IgG. So the figure on the left shows nasopharyngeal culture using Bordet-Django agar, which shows colonies that are small and shiny and resemble mercury drops. On the right is a gram stain smear which shows gram-negative Coccobacilli.
Hi there, I am Aljon Vargas and I will be talking with you for a while. Now let us jump right into our patient's general information. As per the case, it is mentioned that our patient is a 28-year-old female. For the subjective and objective information, our patient's chief complaint when she admitted herself was her manifestation of a dry hacking cough. She has also exhibited other symptoms such as low-grade fever and shortness of breath or dyspnea or dyspnea. Now let us talk about the history of our patient's present illness. Our patient has indicated that for approximately 5 weeks, she already had a cough, and she had low-grade fever at times which was never higher than 38 degrees centigrade. Also, she has terrible coughing spells which are hard to stop, and she complained that her sleep are often interrupted by coughing. She has also been experiencing shortness of breath when lying down. And on the day of her admission in the ER of the Southwestern University Medical Center, she has exhibited and presented a dry hacking cough. Now for the patient's social and drug history, it is confirmed by our patient that she has never received a pertussis booster vaccine and neither is she on antimicrobial therapy.
Good day, this is John Boris, and based on the physical examination, the patient had several episodes of numerous rapid coughs, each followed by an inspiratory effort that includes a high-pitched whoop. Recorded vital signs include a temperature of 37.5 degrees Celsius, which is normal, a pulse rate of 160 BPM, which is above the normal range, that is 60 to 100 beats per minute, and a respiratory rate of 72 respirations per minute, which is also beyond normal since the normal respiration rate for an adult at rest is 12 to 20 breaths per minute. For the pertinent laboratories, complete blood count yielded a result of increased WBC count with absolute lymphocytosis. For the nasopharyngeal culture using the Bordet-Django agar, Colonies seen are small and shiny and resemble mercury drops. The gram stain smear shows gram-negative cocobacilli, and the serologic test revealed positive on IgA and IgG.
I am Mary Rosadrake and I'll be talking about the differential diagnosis and the actual diagnosis. For the differential diagnosis, first, we have come up with pertussis. Pertussis usually starts with a cold-like symptoms with a mild cough and fever. Pertussis can cause a serious illness to babies, children, teens, and adults. Symptoms of pertussis usually develop within 5 to 10 days after you are exposed. Sometimes, symptoms do not develop for as long as 3 weeks. As the disease progresses, the traditional symptoms of pertussis may appear and include rapid coughs followed by a high-pitched whoop sound, vomiting, and exhaustion after coughing fits. So pertussis is caused by a type of bacteria called Bordetella pertussis. The second one is pneumonia. Pneumonia is an infection that inflames your lungs' air sacs. The air sacs may fill up with fluid or pus, causing symptoms such as cough, fever, chills, and trouble breathing. Pneumonia symptoms can vary from so mild that you barely notice them to so severe that hospitalization is required. The signs and symptoms of pneumonia may include cough, which may produce greenish, yellow, or even bloody mucus, fever, sweating, and shaky chills, shortness of breath, rapid, shallow breathing, sharp or stubborn chest pain that gets worse when you breathe deeply, or cough. Influenza is the most often cause of pneumonia. Before coming up with the final diagnosis is first we have to consider the chief complaint of the patient, which is the dry hacking cough and low fever, which eventually leads to shortness of breath, which are symptoms of upper respiratory tract infections. So we have considered two things, pertussis and pneumonia. While doing her physical examination, the patient experienced numerous rapid coughs with high-pitched whoop. She also developed high respiratory rate and fever. So we have come up with the final diagnosis, which is pertussis, or also known as the whooping cough. So pertussis because one of its clinical manifestations is the high-pitched whoop sound, which is also experienced by the patient.
Good day everyone, I am Riz Poblete and this is how we found out what the causative agent is for our case. So we were looking for a gram-negative bacteria that caused our patient's upper respiratory tract infection. We considered the following species: Neisseria species, Bordetella species, and Mycoplasma species. The culture order was a nasopharyngeal culture using the Bordet-Gengoux agar, which showed colonies that are small and shiny and resembles mercury drops. For the Neisseria species, the culture method used are sheep's blood agar and chocolate agar. For the Bordetella species, it uses Bordet-Gengoux agar or the Reagan-Low agar. And for the Mycoplasma species, it uses Hayflick, modified New York City medium or PPLO medium. It is important to know that the Bordet-Gengoux agar is a selective medium used for the isolation of Bordetella species. From this, we can deduce that the bacteria that we are looking for is of the Bordetella species. We decided to focus on the clinically significant species of Bordetella: Bordetella pertussis, Bordetella parapertussis, and Bordetella bronchiceptica. But since Bordetella bronchiceptica rarely occurs or is rarely transmitted in humans, we will be focusing on the other two. Bordetella pertussis and Bordetella parapertussis are both causative agents of whooping cough. From the enzyme-linked immunosorbent assay or ELISA serologic test, the patient tested positive for immunoglobulin A and immunoglobulin G. The two immunoglobulins are detected in both Bordetella species. So, what is the causative agent of our patient's infection? It is confusing to determine whether it is Bordetella pertussis or if it is Bordetella parapertussis with just the nasopharyngeal culture and serologic test. What is the difference between Bordetella pertussis and Bordetella parapertussis? A simple CBC result could make it easier to differentiate. From the CBC order of the patient, it was found out that there was an increase in white blood cells with absolute lymphocytosis. This is a significant indication that the patient has Bordetella pertussis. Bordetella pertussis releases a toxin called pertussis toxin, while Bordetella parapertussis does not. This pertussis toxin causes lymphocytosis, increased interleukin 4 and IgE secretion. So therefore, Bordetella pertussis is the causative agent that caused our patient's upper respiratory tract infection. Thank you.
Taxonomy of the Bordetella pertussis. So it belongs to the domain Bacteria, phylum Proteobacteria, class Beta Proteobacteria, order Burkholdeриalis, family Alkaligenaceae, genus Bordetella, species is the Bordetella pertussis. So the characteristics of this organism is it is small, that's why it resembles a mercury drop in the nasopharyngeal culture. Obligately aerobic, gram-negative Coccobacillus. So the virulence factor of the Bordetella pertussis has three functions, which are the adhesion or the autotransporters, toxicity, and the overcome host defenses. For the adhesion, it has membrane types 2 and 3, a serotype specific agglutinins for the colonization of respiratory mucosa. Filamentous hemagglutinins, or FHA, mediates adhesion to the ciliated upper respiratory tract. Pertactin, or PRN, mediates eukaryotic cell binding and is highly immunogenic. For the last one, tracheal colonization factor, breast tumor kinase A. For toxicity, it has pertussis toxin, adenylate cyclase toxin, demonecrotic toxin, tracheal cytotoxin, and endotoxin lipopolysaccharide type 3 secretion. So the pertussis toxin induces lymphocytosis and suppresses chemotaxis and oxidative responses in the neutrophils and macrophages. Adenylate cyclase toxin hemolyzes red cells and activates cyclic adenosine monophosphate, thereby inactivating several types of host immune cells. Demonecrotic toxin is up until now unknown. The function is unknown, Tracheal cytotoxin is a ciliary dysfunction and damage. Lastly, for the toxicity is the endotoxin liposaccharide type 3 secretion. For the last function of the virulence factor is the overcome host defenses, and it has only two types. So for the outer membrane, it inhibits the host lysozyme, and for the last one, the CD4 production, it prevents the lactoferrin and transferrin from the limiting iron.
Bordetella pertussis produces several virulence factors, of which the fimbriae are considered adhesins and elicit immune responses in the host. B. pertussis has three distinct serotypes, namely the FIM2, FIM3, or FIM2-3. Generally, B. pertussis FIM2 strains predominate in unvaccinated populations, whereas FIM3 strains are often isolated in vaccinated populations. So now let's talk about the characteristics of Bordetella pertussis. So it is a gram-negative small ovoid cocobacilli that measures 0.5 micrometers. It is aerobic, which means that it needs oxygen in order to survive. It is non-motile, non-sporing, and encapsulated. And it should also be noted that freshly isolated strains of B. pertussis have fimbriae. It grows optimally at 35 to 37 degrees Celsius in moist chamber and ambient air. And lastly, it is fastidious, which means that it will only grow when specific nutrients are included in its medium. So, the first medium is the Bordei-Django glycerine potato blood agar, which is the preferred medium. The appearance of Bordetella pertussis in this medium is small and shiny, and it also resembles mercury drops. The second is the Regan-Low media or the charcoal blood agar, which is selective for Bordetella species. Its appearance on this medium is small, domed, glistening, and white or gray colonies. And Bordetella pertussis does not grow in Makgangki agar. So for the biochemical reactions, inactive, it does not ferment sugar. It is positive for indole test, which means that Bordetella pertussis has the ability to convert tryptophan into indole. It is negative for nitrate reduction, which means that it turns red after the addition of the nitrate reagents. It is negative for citrate utilization test, which means that citrate is not the carbon source for this type of bacteria. Urease is negative. Catalase test is positive, which means that there are bubbles resulting from the production of oxygen gas. Oxidase test is positive. Hemolysis, there are colonies on Bordei-Django agar which are surrounded by a hazy zone of hemolysis. So it is also non-motile. So let us proceed to the diseases caused by B. pertussis. Violent bouts of cough can cause subconjunctival hemorrhage, which is a term for a broken blood vessel onto the surface of the eye. Subcutaneous emphysema, which occurs when air gets into tissues under the skin, and if this is left untreated, pertussis can be a serious infection that progresses from the throat and windpipe into a lung infection called bronchopneumonia, which is a type of pneumonia that causes inflammation in the alveoli. It can also cause neurological conditions like acute encephalopathy, which refers to the relatively sudden onset of brain dysfunctions.